your time. That means after half an hour she is in another webinar meeting, and we are waiting for other people to join and putting everybody on join. So it's a Zoom meeting, and I'm always thankful to the friendship of Dr. Gregg and Dr. Colombo and others. And we know we are suffering, all of us are suffering. We never expected, none of the astrologers, the whole of the world, ever said that this pandemic is going to happen like that. And in fact, Mr. Donald Trump himself came about 2 months back, and I was on television for sharing his views in so many channels at that time. Although Wuhan was already suffering, but nobody expected that this is going to happen so long. So I will try to keep my presentation for 10 minutes, and then we will have Dr. Stone speaking, and then the sequence will be, then we'll have Dr. Antonio Colombo if he comes join at that time, and then it will be Dr. Dipti from American College of Cardiology. She will be talking about the American College of Cardiology role. Then we'll have Dr. P.P. Mohanan, who is a President-elect of Cardiological Society of India, who will be talking about CSI role in. I hope everybody is audible for everybody.
Very nicely.
Okay, so after that we will have one or two more. Dr. P.C. Rath said he will do a discussion along with Dr. PK Asokan, and if I am not, then Dr. Ganga Khedkar from Indian Council of Medical Research. He is the Chief of Epidemiology. He has agreed to be a part of it, and our Honorable Minister, Mr. Ashwin Chaubeji, he would like to come in around 8 o'clock, or before that when she free, because he is in a meeting with the Mr. Harshvardhan, and we just spoke. After that we'll have one Bollywood social messages from two people, Mr. Pankaj Jeswani and also Mr. Shabab Sabri, who are the singers there. And just to entertain few, we have Dr. Stone. I would like to tell you for everybody that not only we have doctors here, it's going Facebook Live also, and there is Indians in France, which is also live, showing live this program. So we have non-medical people. So I'll be talking little something which public, for the understanding of public about this COVID-19. This is SARS-CoV-2. We all know the first SARS and MERS came in 2008 and 2002. It's the same coronavirus strain, and but this is more dangerous because of the infectivity, number one, and secondly causing the mortality in various forms. So coming on to the next slide. How to change the slides? Okay, so global perspective as of today. I was talking the WHO slide, seeing, and then we found that 30 million people have been, cases 30 lakh, 3 million people are affected, and deaths 2, that means 200,000 or 2 lakhs in Indian Indian perspective is 29,000 infected and only 939 deaths. Only I speak because when we compare with the data coming from Europe, especially the Italy, Spain and France, and of course US, so we feel happy that with the blessing of God, we're still doing, although our testing rate is not that great as what Germany and France and Spain has done. The US perspective, because Dr. Stone is involved, and I think many US cardiologists are also listening. Today, WHO, just now they were printing it, 10 lakh people. This is how much? It's 1 million. If I'm wrong, people are infected, and with 56,000 deaths, which is very, very concerning, and it's not a good news to share with. And this is not like Spanish flu. I would like to tell you and remind everybody who are listening, medical as well as non-medical people, the first pandemic of the century was around 1902 with Spanish flu, and at that time 4 to 6 crore population, that means more than 400 million people died. 40 million, no, 4-6 is 40 million. 40 million people died, and in India also it was at least 20 million deaths. In crore we are more simple. That means India about 1.5 to 2 crore people died, and generally in general it was 6 crore population died. In fact, the Mr. Mahatma Gandhi ji, Rashtrapita, he also suffered, but he survived, and because he was also quarantined. So today Italian perspective is 1,99,415 people infected and 26,977 deaths. So it's a viral disease. I will go to a little about the virology part also, because I have been talking a little about it. So SARS-CoV entry and replication, this is what the slide is showing. And then there is the antigen presentation, then cellular immunity and humoral immunity. So we have to understand, because we have to understand the plasma therapy and also we have to understand the vaccine, we should know about the histopathology and also the microbiological part. So coronavirus entry and replication, coronavirus S protein has been reported significant determinant of virus entry to the host cells. The envelope-like glycoprotein binds to cellular receptor ACE2, angiotensin receptor 2, for SARS-CoV and SARS-CoV-2. The entry of SARS-CoV into cells was initially identified to be accomplished by direct membrane fusion between the virus and plasma membrane. In 2009, it was found that the critical proteolytic cleavage event occurred at SARS-CoV as protein position S20 mediated the membrane fusion viral infectivity. Coronavirus entry replication, the newly formed envelope glycoproteins are inserted into the membrane of the endoplasmic reticulum of Golgi body, and the nucleocapsid is formed by the combination of genomic RNA and nucleoplasmid protein. In the end, the vesicles containing the virus particles then fuse with the plasma membrane to release the virus. This is how the replication is held inside. While the virus enters into the cells, its antigen will be presented to the antigen presenting cells APC, which is the central part of the body antiviral immunity. Antigenic peptides are presented by MSC or human leukocyte antigen and then recognized by virus-specific cytotoxic T lymphocytes. Currently, we don't have any report about the antigen presentation of SARS-CoV-2, and we can only get some more information from previous researches on SARS-CoV-1 and MERS. But all these things are coming from the earlier strains of coronavirus. And the antigen presentation of SARS-CoV depends on the MSC1 molecule, and MSC2 also contributes to its presentation. Humoral and cellular immunity. Antigen presentation subsequently stimulates the body's humoral and cellular immunity, which are mediated by the virus-specific B and T cells. Similar to common antiviral infection, the antibody profile against SARS-CoV-1 virus has a typical pattern of IgM and IgG production. The SARS-specific IgM antibodies disappear at the end of week 12, while the IgG antibody can last for a longer time, which indicates IgG antibody may mainly play a protective role, and the SARS-specific IgG antibodies primarily are S-specific and not N-specific antibodies. Comparing to a humoral response, there are more research on the cellular immunity of virus. The latest reports show the number of CD4 and CD8 T cells in the peripheral blood of SARS-CoV-2 infected patients is significantly reduced, whereas status at the excessive activation as evidenced by high proportion of HLA-DR and CD38 double positive fractions. So it was all about this. The acute phase response in patients with SARS-CoV-2 become very sick is associated with severe decrease of CD4 and CD4T and CD8T cells. Even if there is no antigen, CD4, CD8 memory T cells can persist for 4 years in the part of SARS-CoV-1 and recovered individual and can perform T cell proliferation, DT response and production of IFN and DG. So coming on to what is cytokine storm in COVID-19, because this storm leads to septicemia, shock, and finally the patient does not survive. The latest report in Lancet shows ARDS, acute respiratory distress syndrome, is the main cause of death of COVID-19. One of the main mechanisms of ARDS, the cytokine storm, the deadly uncontrolled systemic inflammatory response resulting from the release of amounts of pro-inflammatory cytokines and chemokines. The cytokine storm will trigger a violent attack by the immune system to the body, causing ARDS and multiple organ failure, and finally lead to death in the case of SARS-CoV-2 infection, just like what occurs in SARS-CoV and SARS-2 infection. The diagnosis of COVID-19, coming on to the diagnostic part, I will touch upon. I told you that there are people who are from the non-medical side also in this webinar. The clinical diagnosis of COVID-19 is mainly based on epidemiological history, clinical manifestation, nucleic acid detectance, CT scan, and immune identification of technology. So clinical symptoms and signs are very important, but they are sometimes atypical, and there can be including respiratory symptoms like cough, fever, which is dry fever and dyspnea and viral pneumonia. Nucleic acid detection, which is the most important part of detection, it is the most important part of diagnosis, is RT-qPCR test, which is done from the respiratory tract secretions and respiratory tract secretions. But however, RT-qPCR is a specific test for diagnosis of COVID-19, but sometimes it can be false negative. A lot of people don't know about this. They feel that RT-PCR, which is the final test, can also be false negative, but this false negative cannot be ignored because of severe consequences of misdiagnosis. If you miss a diagnosis of a patient who has a clinical symptom of fever or dyspnea or uncomfortable or breathing difficulty or cough, the CT scan can be considered necessary auxiliary diagnostic method because it is more sensitive. Which means to say the CT scan is more sensitive for individuals with a high clinical suspicion of SARS-CoV-2 infection with negative RT-qPCR screening, negative RT-PCR test, combination of repeated RT-qPCR tests and CT scan may be helpful. Especially the high resolution CT scan for the chest is essential for the early diagnosis and evaluation of disease severity. This is how the CT scan looks like. The typical CT scan shows bilateral pulmonary parenchymal group glass and consolidated pulmonary opacities, sometimes with a rounded morphology and peripheral lung distribution. Testing is the key to success. We have been doing the testing in India with RT-PCR testing, and now the antibody test has come up, especially the Chinese, the kit has come. But I would like to tell you that testing in India is about 400 population, 400 people per million, while in Germany it was about 26,000. For US, if I remember the correct figure, is about 6 to 8,000. France is about 8,000. Germany is the maximum, and Spain, Italy about 6, 7, 8,000 per million. India is still struggling to match the same thing because of the number of population, and also the initially only the government hospital were doing the testing. Now in the private hospital, like Apollo Hospital, is doing the testing. So initially, now in the hospital, it is very important to tell you that every patient who is coming to our Apollo Hospital for any other non-cardiac or non-COVID or for any purpose has to be tested negative before we admit. This is a recent guidance since yesterday, and today I discharged a patient who was supposed to do angiography, but he said, will he be required to repeat the test? Yes, even after 1 week, if somebody is testing, getting again admitted, we have to do it. So as such, the Delhi is testing about 1,000 people per million, but overall India is about 400. I told you Germany is about 25 to 26,000, and that is why they are able to contain it. Coming on to the testing part, coming on to the medicine part, how the medicine work, I would like to share this diagram which is taken up from one of the pathophysiology of SARS-CoV-2. This is how the virus enters. I'm a little fast because I have to keep pace and other people have to speak, and I want to finish my slides. So SARS-CoV-2 enters into the cell, inhibits TMPRSS2, prevents viral cell entry. Membrane fusion endocytosis is the first part. Here this is hydroxychloroquine is working. At this point of time, hydroxychloroquine work, while the antiviral medicine like lopinavir, duranavir, ribavirin and remdesivir, which have still a not 100% confirmatory role in COVID-2 virus, because no drug has shown to be 100% surety except for ivermectin, which is only for the in vitro test. So this is where the other viruses are working.
आवाज नहीं जा रही वहाँ पे किसी को भी सभी कंप्लेन आ रही है आवाज नहीं जा रही है अनम्यूट करके म्यूट करो
Just a minute, I think, are you able to hear me or no? Can you hear me? Can you hear me? वो चला गया उसको आता ही नहीं वैसे नहीं अनम्यूट हो गया क्या हम
नहीं
ये म्यूट हो रहा है यहाँ पे
नहीं पहले अनम्यूट थे फिर भी आवाज नहीं जा रही है जब कंप्लेन आ रही है कि म्यूट फोन में लॉजर आएगा उसको बंद कर दो
cytokines and chemokines which are released, and this leads to ARDS in the cytokine storm, the deadly uncontrolled systematic inflammatory response resulting from the release of amounts of pro-inflammatory. The cytokine storm will trigger a violent attack by the immune system to the body, causing ARDS and multiple organ failure, and finally lead to death. As it happened earlier in SARS-CoV-2, just like what occurs in SARS-CoV-1. The important part which you all missed was that the clinical history is very important. We know that symptoms of cough, fever, and then we do the testing of RT-PCR. But the most important part of this is that RT-PCR is a nucleic acid test detection technology, which is supposed to be 100% proof. But this is actually not the case. This is taken from the respiratory secretions. But there is also a possibility you can do from the blood. But the respiratory secretions are there. But radiological diagnosis is important because sometimes there is a false negative rate which cannot be ignored because of severe consequences of misdiagnosis. Hence, CT scan can be considered as necessary auxiliary diagnostic method because it's more sensitive. It's more sensitive. For individuals with a high clinical suspicion of SARS-CoV-2 infection, with a negative RT-PCR screening, a combination of repeated RT-PCR tests and CT scan can be helpful. Especially the high-resolution HRCT for the chest is essential for diagnosis and evaluation of disease. HRCT shows a ground glass appearance. Transfer chest CT of 40-year-old man showing a bilateral, lobular and subsegmental areas of consolidation. The typical CT scan shows bilateral pneumonia patch, parenchyma and consolidated pulmonary opacity, sometimes with a rounded morphology. So this is how we make a diagnosis. Testing is the key to success. I was telling that India is lagging behind in testing. We are testing about 400 people or person per million, while US is testing about 7,000 if I correctly figure per million. Germany is maximum at 25,000 per million. South Korea about 18,000 per million. This is the testing that they are doing with the RT-PCR. France and Spain about 7 to 8,000. We are still doing the best in Delhi because we are testing about 1,000 population per million in Delhi, as was the report which was published day before yesterday. But in general, 400 people are being tested, and now we are increasing the testing capacity. India is a huge country with 137 crore population, and therefore the things are not so easy for us to manage. But still, we are able to manage a lot. Out of all the states, the Delhi is doing the maximum testing about 1,000 per million. But US is not doing that great. They are doing about 8,000. I repeat. But Germany has done the best and South Korea have done the maximum testing. How the medicines work? As such, there is no specific medicine as of now for COVID-2 which can really kill, except the intervectin, which is ivermectin, which is only applicable in vitro as of now. But there are auxiliary tests which are there. This is the diagram where I left. This is how the virus enters into the cells. And there are various medicines which are working at various levels. Antiviral medicines may help. As of now in Apollo Hospital, we always give all the patients hydroxychloroquine. I'm talking of COVID-19 positive patients. We are not talking of prophylaxis as of now. So hydroxychloroquine works at the membrane suffusion and endocytosis, while the antiviral ribavirin, remdesivir and favipiravir, they're not easy to pronounce. They work at the RNA-dependent RNA polymerase chain reaction here. They are working. While tocilizumab and sarilumab, they work at the endoplasmic reticulum level. Coming on to the hydroxychloroquine, which has made a huge news all over the world. We all know this is a brother of chloroquine, which is anti-malarial. Hydroxychloroquine is being used by the people for the autoimmune disease like rheumatoid arthritis and SLE. This is a simple medicine which is not very expensive. So it came into picture because Wuhan did a technological test in Wuhan and they found that this is effective. I'll show you the results of Wuhan lab before going on to the French test. So this is the first test which was done in Wuhan, which was published, and this is how they showed. They showed the conclusion. Despite fewer number of tests, SCQ in the treatment of COVID-19 has partially we considered to be better option at present, promising there, and this was February 2020. But after that, there has been a study from the France, Marseille, which is very, very positive, and they say, this is Professor Didier Rault. After the Wuhan study in February, Professor Didier Rault, who works in Marseille, in ICU Mediterranean, he's a virologist, he was very, very critical. This is a paradox. He was initially very critical. I saw the video, he said hydroxychloroquine should not be used. But by the same time, he was doing the testing, and he has done a testing, the result of 1,016 COVID-19 patients treated for at least 3 days with hydroxychloroquine with azithromycin combination. And a follow-up of 9 days was investigated by this team. And the results were no major cardiac toxicity was observed by this study of 1,000 people. A good clinical outcome and virological cure was obtained in 973 patients within 10 days. 91% success. A poor outcome was observed in 4%, while 5 patients died out of 1,000, which is only 0.47. Let me tell you, the mortality of COVID-19 as such, in general, is about 10%. In patients who are cardiovascular, about 15%. A patient more than 80 years, around 20%. In general, about 5 to 7%. Various studies have shown. So if you reduce the mortality to only 0.47% with a combination of azithromycin and hydroxychloroquine, this is a very positive result from the French perspective, and this was published in April 9, 2020. This is from Professor Didier Rault in Marseille, France. So, but coming on to what the US says, because American guidelines are equally important, the emergency use authorization of hydroxychloroquine version 28 March. What the US FDA said, US FDA has issued a EUA to permit the emergency use of hydroxychloroquine sulfate supplied by the strategic national stockpile to adults and adolescents who weigh more than 50 kg and are hospitalized for COVID-19 for whom a clinical trial is not available. So this is what the FDA told on 28th of March. But recently there has been another guideline, and I think based on this, Mr. Donald Trump, the President of USA, was actually looking at Mr. Narendra Modi, our Prime Minister, whom I have been knowing for last almost 10 years, that they should not stop the export of hydroxychloroquine to USA. And finally our Prime Minister gave the nod that this will not be stopped because we have enough pile. So this was at that time when it was known as a huge figure when US FDA gave emergency use. What is the US FDA guideline for April 25? The April 25 guideline says US FDA warns against, now they are warning against the use of hydroxychloroquine to treat COVID-19. US states built stockpiles of hydroxychloroquine after it was touted by Mr. Trump, as a treatment for coronavirus. But at the same time, they said US FDA warned against taking anti-malarial drug touted by Mr. Donald as a possible treatment. But Trump has, but they say no conclusive tests have been completed to prove its effectiveness. But Mr. FDA Commissioner Dr. Stephen in a statement, we understand the healthcare professionals are looking for every possible treatment option for the patient, and we want to ensure we are providing them with the appropriate information needed to make them the medical decision. While clinical trials are ongoing to determine the safety and efficacy of these drugs for COVID-19, there are no side effects of this medication. So overall, they say that hydroxychloroquine are approved by the FDA to treat malaria and other ailments, but as such, you have to take care. Our view, personal view, myself and our cardiologist view is, if there are no cardiac disease in a patient of COVID-19, if the QT interval is normal, then there is no need to worry and you can still go ahead with this. I would like to tell you the ICMR guideline. I don't know whether Mr. Khedkar is there with us or not. The ICMR guidelines, Indian Council of Medical Research, which is a very important body of research, they gave the guideline for all the people of healthcare workers to use hydroxychloroquine in a specific dosage. And the dosage which they told was 400 milligram of HCQ once, only one day, BD, and then repeating 400 milligram once a week for 7 weeks. Once a week for 7 weeks. So this was as such not a huge dose. And as a cardiologist, I must say that there is no major reason to worry about the QT interval. And as such, and there was recently some study from USA about 200 patients only, which they said that the mortality was increased by hydroxychloroquine in COVID-19 patients. So there is still a confusion, but for healthcare workers, I must tell you that through this webinar, they should take 400 milligram twice a day, only for one day, and then repeat only once a week for 7 weeks. This is Indian Council of Medical Research guideline published about 2 weeks back. So coming on to the other part of the diagnosis, I will try to finish in 10 minutes, next 7 minutes, then we'll have Dr. Gregg Stone. Role of ivermectin. Ivermectin is an anti-parasite body which is FDA approved for the anti-parasite treatment, not for the COVID-19 as of now. This has been shown to have a very good result. By 48 hours, the effect increased to 5,000-fold reduction of viral RNA in ivermectin treatment compared to control sample, indicating that ivermectin treatment results in effective loss of essentially all viral material within 48 hours. This is only in vitro. The hypothesis is the effect is likely through inhibiting IMPA B183 mediated nuclear import, and we need to have the human trial as of now. The in vivo trial have not happened as of now. I don't know which company is doing it. This is an in vitro trial needed to conduct. France should continue. There should be a clinical trial. This is the only medicine antiviral which is an anti-parasite which has shown to reduce or finish off the virus within 48 hours in vitro. So this is very interesting and therefore we should do it. For the public, I'm trying to give another 3 minutes to tell you how to use the mask. We all know there are 2 types of mask available. One is 3-ply, which is surgical mask, which another is N95. When we were struggling during the first week of March and February, and there were a lot of debates on television whether everybody should be allowed the mask or not. So I told at that time, I would like if you can hear this video, which I have put it. I was on television. This is 26th of March when I was asked the question, whom to should mask.
There is a possibility that asymptomatic carrier can also infect the people जिसको बताया कि 5-6 दिन तो लग जाते हैं फीवर आने में. दूसरी पॉसिबिलिटी है कि the virus can also sustain in the air. तो ये बात को देखते हुए अगर हमको मैं कह दें कि not only social distancing, not only quarantine, not only self-discipline, but mask available नहीं है. 100 रुपए के मास्क मिल रहे हैं.
This is what I told on 26th of March, that everybody on the road should be wearing it. At that time, people laughed at me and they said that this is not practical and this is not as of now. The similar thing I spoke on 29th of March.
हमारे जितने भी लोग काम कर रहे हैं, बॉर्डर पे खड़े हैं, जो अधिकारी हैं, जो पुलिस वाले हैं, जो वर्कर हैं, उनसे कहा जाए कि जितने भी लोग हैं, आइदर मास्क और रुमाल और अंगोछा, तो हम इनको रोक पाएंगे. 80% 90% लोगों को, बाकी लोगों को संक्रमण करने से.
So this is what I want to tell you. Actually, why I was showing this video was because at that time people did not believe me, and I am very fortunate that Honorable Prime Minister Mr. Narendra Modi himself weared a gamcha or angocha after about 1 week of this. At that time people said it is impractical, don't create panic, it is impossible, and there is no need for anybody who is coming out on the road. Despite the lockdown, there are a lot of people who are coming out on the road. They did not believe me, and they said, I said that asymptomatic carrier can be there. People, you don't know who's there. Wherever you're going for mother dairy or coming out for the vegetable essentials, despite the lockdown, you can be infected. So I was very happy that later on it was considered. What is the vaccine? Coming on to the vaccine is most important. I was reading a newspaper article and also the television show. They said normally lockdown should continue till the vaccine is coming. But as of WHO, Dr. Andrews, vaccine cannot come unless there are human trial, and which will take about 8 to 12 months. But recently we have a good news. COVID-19 vaccine likely by September, says Indian firm pioneering Oxford. Coronavirus, most of scientists have said vaccine is not expected in the market before 2 years to minimum 18 months. But today there was a human trial of Oxford vaccine, one of the more than 100 being developed across the world. There's so many virus agencies, there are so many virologists who are developing vaccine, but none have been still, the human trial has not completed or not started. Only on April 23, the first human trial started, and you must be aware that the French lady who was a virologist was the first person to take the vaccine herself, and she said, I am volunteering myself. The clinical trials of 7 others, some of them located in China and US, are also being held, reported news agency AFP, quoting the London School of Hygiene and Tropical Medicine. So this will take another few months to come, but vaccine will be the only answer for this. And United Nations pushes for the global vaccine effort, and the Bill Gates Foundation has donated a huge money. The Bill Gates from USA, he's a philanthropist, has donated a huge money for the same purpose. Contact tracing. This is a very important slide. I'll just give you another 30 seconds. I will tell you. The contact tracing is an app which is developed by Ministry of Health and Family Welfare. I'm sure America and Italy must also be having similar apps. This is an app which is known as Arogya Setu. Everybody who has an Android phone should download this app, and with this app will tell you that you will be, if you are coming in contact within 14 days to somebody who is infected. For example, Mr. X is having Android, he gets infected, he will put a notification on the phone, then this notification will go to all the people who has come in contact within 2 meters with that person, that you have been in contact with Mr. X who has now got infected, and therefore you should quarantine yourself. This is better than social or physical distancing, and I would request everybody who is listening on the Facebook or otherwise to please download the Arogya Setu app, which is available on Ministry of Health and Family Welfare guideline in India. I do not know, similar app must be available in US as well in Europe, but they have to have this contact tracing app. This is a 1 step or 2 step ahead of social and physical distancing, because you can find out yourself that within 14 days you are actually in contact with somebody who is now infected, and therefore you should quarantine yourself, test yourself, and wait, and you should not try to infect others. There are a lot of European studies which have come up recently. The recovery trial for antiviral medicines, are not going to details. Plasma therapy has been there very much. I told you there are no major medicines which can be actually 100% effective except for ivermectin, which is not tested in humans, it is only in vitro. Plasma antibody therapy, which we are doing for last long minute, I showed you initially in my earlier slide, that IgM and anti-IgM antibodies are produced by the body. So we all know that vaccine works by increasing the immune response for the same virus, while plasma is actually, this is a very simple thing, that when the patient who is recovered from COVID-19, his blood is taken, transfused, the plasma is taken out and transfused back, into the COVID-19 patient. But let me tell you, this is a treatment modality only for very sick patients who are likely to get ventilation, who have severe pneumonia, ARDS, not for the routine patient. 80% patient of COVID-19 will recover on their own, 80%. Only 10% will become sick, and out of those 20% will become sick, and out of those 10 will die despite whatever you do. So this is a plasma treatment, will be very useful. India has started trials, and in Delhi about 6 to 8 patients have already been treated by this. Herd immunity is very important. I was told, and I'm sure, that Stockholm, where the Nobel Prize is given, where of course I would say that Mr. Gregg is still mandated. I'm sorry, this is different. Stockholm, the Sweden, has not put a total lockdown. They are believing on the theory that the herd immunity will develop soon. What is herd immunity? For the public and for other doctors to know, Herd immunity means you get the infection, everybody is infected, and this is a very simple diagram to show. If you see on the level on the left side, the blue one, no one is immunized, contiguous disease spreads throughout the population. Red people are not immunized, sick and contiguous. They are infected. Some of the population gets immunized by themselves. Contiguous disease spreads through some population. And finally, when the herd immunity is there, the yellow, you see the orange people are actually those who are getting the immunity and they recover. This is what is happening with normally all flu. The flu has been common thing. We know the viral disease is very common. In general, we don't scare from the viral disease, but this virus is more dangerous than the normal common flu, and therefore this is to be taken. A herd immunity has to develop, but how long will it take? Whether it will be useful or not, because the 80% only will be normal, 20% will be sick, and this is more dangerous than other common flu virus. Ventilator treatment is the only resort method which can really help in this. But many patients, let me tell you one more pathophysiological part of this virus. This virus is actually working at the level of cells where it dissociates heme from oxygen. It does not cause the dissociation of heme from oxygen, and therefore the patient at the alveoli level, at the level where the oxygen exchange happens, it disturbs that. And one theory is that hydroxychloroquine actually helps at the level of porphyrin. It is bind to the porphyrin and it reduces the virus load at that level. So in India, a lot of people are very scared of ventilator, and there have been so many TV programs that hospitals are using ventilator to earn money. Let me tell you very honestly, it's a life-saving. We have to have. In the US, there was a paucity of ventilator. In Italy, there was paucity of ventilator, and that is why what happened is there was this news also that in Italy the doctor has to choose between an elderly patient versus a younger patient who both are sick, and since the ventilator only one is available, so they have to choose whom to give. Now India has acquired more number of ventilators than actually at the moment is needed, and everybody is happy. But let me tell you, this is important. Healthcare workers are already told sanitization, social distancing, mask, N95, I would say. But there have been some guidelines that N95 only for those who are actually treating the COVID-19. We have the shield, the PPE, personal protective equipments which are on sale. And of course, I tell you that Indian Council of Medical Research has confirmed the guidelines to hydroxychloroquine 400 mg once only, 1 day BD, and then once a week for 7 weeks. Role of China. I want to read this, very important, although I am not a politician. But still, Japan Professor of Physiology of Medicine, Professor Dr. Hanjo, who is a Nobel laureate, created a sensation 3 days back in front of the media today by saying that coronavirus is not natural. If it is natural, it would not have adversely affected the entire world like this, because as per nature, temperature is different in different countries. If it is natural, it would have adversely affected only those countries having same temperature as China. You say it is spreading all over the world. The same way spreading in the desert area where if it were natural, it would have died in hot places. I have done 40 years of research on animal and viruses. If it is not natural, it is manufactured, and virus is completely artificial. I have worked for 4 years in Wuhan laboratory. He has worked in Wuhan laboratory. He's Japanese professor, Dr. Honjo. I understand the things very well. Based on all my knowledge and research till date, I can say that this 100% confidence that coronavirus COVID-19 is actually artificially made. China has manufactured it. I am not going to be politicized, but it's very interesting to read. If what I am saying today is proved false, even now or after my death, the government can withdraw my Nobel Prize. This is saying that even if I am proved wrong, even now or after my death, the government can withdraw my Nobel Prize, but China is lying in this truth. So I am not going to detail, but I wanted to read this, that he says that my Nobel Prize may be withdrawn if I am proved wrong that this is a natural or artificial virus. The infants which are born to COVID mothers, they are not infected. I am not going to details. This is an important slide, but it's not important. Those patients who are born, they are infected, but their children, the infants which are born, they have only immunity, but they are not having antigens proved. COVID and heart, I think Professor Stone will tell more about it. I'm not going to tell you. I want to show you the last slide, which is important for the people to know, especially that is regarding the mortality. This is an important slide I want to tell you. The overall COVID-19, this is actually published in February 24, which is my birthday also, not 2020, which is JAMA published it. Overall mortality they have shown was only 2.3%. I think this has been proved wrong. It's about 5 to 7%. But more interesting thing, those patients with cardiovascular disease are having the mortality of 10%. With diabetes, 7%. More than 80 years, 14%. 70 to 88% only. But what is a paradox is the patient who are respiratory disease. Although this is a respiratory virus, the patient with a chronic respiratory disease are having only 6.3% mortality, while the patient with cardiovascular disease is 10%, which is again very high. The bypass surgery, in fact, the most of the important high-risk bypass surgery is only 2% risk of death. Here it is. Last thing which I want to tell you for the Indian people, otherwise, the tuberculosis as such is a bigger killer per year. So there was a data coming on the WhatsApp and otherwise that what is more important, the tuberculosis, or it is the importance is what is more important, the tuberculosis or the mortality of COVID-19? So I always tell, COVID-19 will kill the person within 3 weeks. Tuberculosis will not kill. Overall, the number of people dying in India or in underdeveloped or developing countries is more than COVID-19 deaths in general. But here you are losing the dear one within few weeks' time. This is separate. So you don't try to compare that this COVID-19 mortality is less. This is more tragic. We have to find solutions. Vaccine has to come, and we have to have panel discussion like this. I'm thankful to other panelists to bear with me for last almost 25 minutes. I'm sorry to take that much of time. So let me introduce my friend Dr. Gregg Stone. If he's listening to me, he is a cardiologist. I will stop the screen now. I can see Dr. Gregg Stone. I can see on the full screen. He is a great friend. He is a director of TCT. And TCT, let me tell you, for the people who don't know, there are a lot of physicians here. TCT is Trans-Catheter Therapeutics. So Catheter Therapeutics, which was launched about 25 years back, I think, with himself and Dr. Gregg, Dr. Martin Leon. I've been attending this for last almost 20 years. This is the greatest meeting of interventional cardiologists with more than 25,000 people attending every year. This is held normally in Washington earlier, and now they are transiting to other places. And last year it was San Francisco. So, and he's also the professor of medicine. He's a chief advisory board member of the Mount Sinai Health and Heart Care System. He's a very, very educated. He's an eminent and most celebrity interventional cardiologist of India. And I thank him for coming online for this webinar.
Well, thank you, Vivek. A terrific talk, a lot to cover about COVID-19. It certainly has changed all our lives, particularly in the United States. So I'll give you a little bit of perspective about what's going on in the United States with COVID-19, and then perhaps a little bit about COVID in the heart. As you saw, you showed the numbers that we're now over 3 million worldwide cases and over 200,000 deaths. I think, first of all, we have to take those numbers with a little bit of grain of salt in terms of the uncertainty. I think we're probably markedly under-diagnosing the number of cases of COVID-19. I don't know exactly what this is like in India, but in the United States, if patients have symptoms consistent with COVID-19 but are not severe, they're told not to come to the hospital and not necessarily to get tested, but just treat, stay at home with conservative measures as if the patient does have COVID-19. And those cases are not being counted. So we're really only counting, at least in the United States, the severe cases, those cases that require hospitalization. In addition, we're probably markedly underreporting the number of deaths. Of course, patients who die at home and don't come to the hospital are not getting tested. In addition, it's very difficult to tell, even in some deaths, other than a clear ARDS case, for example, whether or not COVID-19 caused or contributed to the mortality. Probably the best indicator that we have is by looking at the annualized rate of deaths in countries or cities or regions, what it's been like for this period of time over the last several years compared to what it's like now. And when you look at those types of numbers, epidemiologic numbers, you probably see that the rate of deaths are doubled right now in most municipalities. And that's interesting because it takes into account that deaths from motor vehicle accidents are down because there are many less cars on the street. Deaths from homicides are down, and deaths from accidents are down. So the fact that the number of total deaths are double means that COVID is probably more than doubling the number of total deaths. And in many series now, COVID-19 has become either similar to cardiovascular disease or even greater than cardiovascular disease as the number one cause of death within the last month. So that being said, again, take with a grain of salt the number of deaths, but if there's over 3 million in the world and if there's over 200,000 deaths in the world so far, The number of cases in the United States is about 1 million. So 1 out of 3 cases in the world is in the United States. And the number of deaths has been reported to be over 50,000. So about 1 out of 4 deaths in the world are in the United States. So the United States has totally become the epicenter of COVID-19 for the world. And if you look at where in the United States, of course, the United States is 50 different states, and that's kind of like 50 separate countries in many ways, in terms of their economies, the agrarian versus citywide living, etc. The environments and the climates are very different, etc. And if you look at that, New York State, one of the states, the state that I work in, has had over 300,000 cases now. So approximately 1 out of 10 cases in the world that's been diagnosed has been diagnosed in New York City. And they've also had over 17,000 deaths. So again, looking at the United States, about a third of the cases and a third of the deaths are in New York State. And when you look in New York City, about 60% of the deaths and cases are in New York City. So over 160,000 cases and over 12,000 deaths just in New York City alone, which is really remarkable. When you look across the United States, it's very variable. There are some states that have, if you look at per capita, per 100,000 people, for example, that have very low rates, that have 100 or less cases, per 100,000 people. You look in contrast at certain areas of New York City, and there's over 3,000, even as high as 5,000 to 10,000 cases per 100,000 people. So now you're talking about a huge percent of infected people. Why is there such a different distribution? Well, it's not just population density. For example, there's great population density in New York, but there also is in Los Angeles on the other coast. But on the other coast, the penetration of COVID-19 is much, much less, and the number of mortalities are much less. Some people have said this might be because there's 2 strains of the virus, and genetic testing has identified that the west coast of the United States has got the virus mostly from migration from China, whereas the east coast has gotten the migration mostly from Europe. And it's possible that those strains are different. And as you know, in certain European countries and capitals, this virus has truly ravaged their societies. But it also depends on how early the social distancing measures were taken in place and other social factors. In New York, there's been a total lockdown now going on a month, where people are unable to leave their homes except for essential activities. So in New York City, basically almost all stores are shut down, all hotels are shut down. In fact, hotels have been converted into either COVID facilities or facilities for the homeless. Restaurants are only allowed to stay open to serve takeout. So you're not allowed to eat in a restaurant anymore. And the streets of New York, which as everyone who's been to New York knows, are tremendously bustling, kind of like New Delhi and other busy Indian cities, now is like a ghost town. There's just a few people, other than police, up and down the streets of New York. In contrast, the hospitals have really been turned into COVID units. So I can tell you the Mount Sinai health system, which is 7 main hospitals, have been running at its peak about 2,200 COVID inpatients per day. 2,200. And about 500 of those were in ICUs, and about 400 of those were intubated. Patients, when they're intubated, they tend to stay intubated for about 2 weeks, and as you know, the mortality has been running 50% or greater. Almost all the patients who survive get a tracheostomy. But the good news is that I would say about 2 weeks ago, the United States hit its peak in terms of the number of new cases per day. And I would say for about the last 2 weeks, in the entire United States, that number has been overall relatively stable, sometimes dipping down a little bit, sometimes dipping up a little bit. So it's not like we've peaked and the number is decreasing, but it has peaked and the number is flat. In New York, the number is decreasing. and we've seen kind of a steady decrease. So it's very regional. It's state by state. It's city by city. So many of the states have also had very severe and rigorous shelter-in-place policies that have been put in place. And, of course, this has devastated the economy in the United States and around the world. But we're very confident that that's going to come back. It's just a temporary thing. The economy is very strong, but it's been put on hold during this crisis. The real question is, how fast can we open up the country again? And as of this week, actually, some cities or states or regions are very carefully starting to relax some of the restrictions. So either allow some stores to open or some activities to take place with suggestions, though, for social distancing. And there's obviously concerns that the relaxation of those restrictions is going to lead to, again, an increase in the number of cases, and we'll just have to see if that is the case. In New York City, there is no relaxation of any of the rules that are in place right now, which I think is appropriate because of the marked number of cases that we still have in the city. With that being said, we are seeing a decrease in Mount Sinai, which I said peaked at about 2,200 inpatients per day. We're now down to about 1,300 inpatients. So it is decreasing, and it's been decreasing every day over the last 2 weeks. The number of ICU patients has decreased from about 500 to about 300. So we are making progress. It's been at a big cost because of all the social distancing. So a few things about the medical aspect of the disease. Hold on just 1 second. Phone is ringing. Let me make sure it's not here. Nope. That's fine. So a few things about the some medical aspects of the disease, and then I'll stop. We've got to remember that despite the fact that we're in this crisis and the mortality rates are very high and everybody is desperate to find a cure, we can't stop doing good science. Regarding hydroxychloroquine and azithromycin, I will say at Mount Sinai we probably started treating everybody with hydroxychloroquine and azithromycin based on some very early reports that suggested reasonable response rates, but those were uncontrolled studies. And as you know, there's no randomized trials. And now we're starting to see data that comes out, which has led to the varying FDA advisories suggesting that it's possible that these drugs are either ineffective or actually may be associated with increased mortality. So now we basically stopped using hydroxychloroquine and azithromycin in almost all patients in the Mount Sinai Health System. So those patients should really go into prospective randomized trials. And I don't think we should be using these types of drugs just because we see something that might work on an experimental test in terms of decreasing viral replication or entry into cells, etc. A second big question has been this relationship between hypertension and angiotensin-converting enzyme inhibitor and receptor blocker use. And as Dr. Gupta showed, the ACE2 receptor, which is in very high concentration in the lung and other organs, seems to be the entry point, the integrin receptor that's the entry point that binds to the spike protein of the SARS-CoV-2 virus. So the question is, should people with hypertension, which does seem to be a risk factor for both getting COVID-19 and then developing severe manifestations of the disease, does it help or does it hurt if they're treated with ACE inhibitors or ARBs? Because that can upregulate the number of ACE2 receptors. So nobody knew. The society said until we have data, patients should continue those drugs. And now we have 2 reports out in the last week, both from China, one a large multi-center experience suggesting that use of ACE and ARBs in hypertensive patients were associated with decreased mortality, whereas another one found no significant relationship. That was just a single center. So it seems like right now patients should continue ACE inhibitors and ARBs if they do have hypertension. A third interesting phenomenon is patients who have elevated troponins. Approximately 20% of patients with COVID-19 have elevated troponins, and this comes from a variety of different sources. Some patients have true acute coronary syndromes with type 1 myocardial infarction. Probably the majority of patients have supply-demand mismatch, either with or without underlying cardiovascular disease, either cause of arrhythmias or hypoxemia or other causes. Some patients get myocarditis, although it does not seem to be direct viral infiltration of the heart. It seems to be a secondary myocarditis due to marked inflammation in patients who get cytokine storm. There can be other causes, including Takotsubo, etc. But what is very clear is that patients who get troponin elevations are at markedly increased risk for mortality, probably about 5 times greater mortality. What to do about these patients is unknown. If they really do have obviously a type 1 myocardial infarction, in general they should undergo primary PCI if they've got ST segment elevation, or if they have, again, a chest pain syndrome consistent with non-ST segment elevation and a high-risk ACS, then they probably should go to the cath lab as well. Whereas low-risk ACS patients, such as those with GRACE scores less than 140, can probably be treated conservatively. There's probably a great role for CAT scans, CT angiography to rule in or rule out coronary disease. It's becoming the non-invasive test of choice in COVID-19 because it's a very rapid test, and so it requires minimal interaction with healthcare providers, so it decreases the risk to healthcare providers. But of course, before taking any patients to the lab in this pandemic, everybody should be wearing full personal protective equipment and take the extra time, even if it takes 15 extra minutes in an ST segment elevation myocardial infarction. We'll be starting a randomized trial of colchicine in troponin-positive patients with acute coronary syndromes, troponin-positive COVID-19 patients. And of course, there are many other randomized trials that are being done with a variety of agents in troponin-positive and negative patients. The last thing I'll say is another interesting phenomenon that's being noted is that these patients seem to have a hypercoagulable state. About a third of them are D-dimer positive, about a quarter have increased fibrinogen levels, and autopsies have shown some evidence of disseminated intravascular coagulation. For example, pulmonary artery thromboses and venous thromboses in situ can be contributing to the VQ shunting and problem oxygenating patients with COVID-19. Again, the question is what to do about all of this. We are, cautiously anticoagulating a lot of patients with apixaban, 2.5 milligrams twice a day, the low dose of apixaban. Whether that's the appropriate thing to do, I have no idea. Certainly, patients who are inpatients should at least be receiving prophylactic unfractionated heparin or low molecular weight heparin. And there are studies that are ongoing to look at intermediate or full dose anticoagulation in COVID-19 patients. But again, I would caution people against kind of shotgunning any approach just on the basis of pathologic findings or other indices until we really have data. Because there's no doubt that we can do harm. These patients also have a propensity to bleeding, and we're seeing some bleeds. So I think we have to, again, not discard good science in this pandemic. So I think I'm going to close, but the bottom line is obviously this is something that's affecting everybody's life around the world. I totally believe with what Dr. Gupta said about wearing masks, social distancing. This is very serious. I will say the virus does seem to have two phenotypes. About 80 to 85% of people seem to have a just moderate flu, and then they recover. And yes, then you'll develop antibodies. We don't know if those antibodies are protective yet, though, and that's very important. We don't know if they're neutralizing antibodies or if they're just antibodies signifying that it was infected. So the use of antibody tests is unknown right now. But about 15 to 20% of patients will develop this very severe phenotype with the cytokine storm that can lead to very, very rapid deterioration of ARDS, cardiovascular collapse, etc. So this is very, very different than influenza. Hopefully we'll be able to develop treatments and a vaccine, hopefully treatments this year, hopefully a vaccine next year. We've got a long way to go. We've got to work together on these types of international communications as we're doing on this webcast. And it's been my pleasure to be invited to share